Hi guys, we'll just wait a couple more minutes to allow everyone to join and then we'll start the talk. Hi guys, so I think we'll get started now. My name's Holly. I'm a Foundation Year 1 doctor working at Aintree Hospital and I'm currently on ENT. And I'm the Vice President of Thursday 15. And I've got with me Katie, who's going to be answering all of your questions in the Q&A and in the chat. So if you do have any queries, any questions, just type them in the chat or in the Q&A and Katie will answer them for you. So if you've never been to one of our talks before, we are Thursday 15. We base our sessions on 15 multiple choice questions, and then we'll use the answers to those questions to explain some topics. They're all based at sort of final year level, and this is just a quick plug for our Facebook page. And this is our Instagram. We have MCQ Mondays, so we've got MCQs on a variety of different topics. And tips on Thursdays that might be based towards your finals or towards F1. Okay, and so the format of the session is it'll be 15 MCQs, and today we are covering diabetes and endocrine. You'll need a pen and paper to hand, so if you write down all of your answers for those, we'll then go through each question. Sorry, I'm not sure if my internet connection's a little bit dodgy. Katie, can you hear me okay?
Yeah, I can hear you.
All cool, good. Okay. I was just blurring a bit on my screen, so I just wanted to check. We'll then go through those questions and I'll get you to vote for what you think is the correct answer on a poll, and we'll have a brief explanation. At the end of the session, there's a link to a feedback form, and if you could fill that in, we'd be really grateful. We really do read your feedback and we respond to it. We're trying to make our sessions more concise and overviews rather than thorough explanations of the topic. And I'm sure Katie will be able to put the feedback form link in the chat if any of you have to leave early. Alrighty, it will be a minute per question. So as I said, pen and paper ready, or your notes page on your phone, something like that. It might be slightly less than a minute for some of the easier questions, and the questions will move on automatically. Okay, here we go. Okay, so that's the MCQ part of the talk over. So hopefully you've got a list of answers in front of you, and we'll start working through the questions, and I'll read out the question and then I'll start the poll. So if you just put your answers in the poll when I start it. So this first question, a 23-year-old female is newly diagnosed with type 1 diabetes. Which of the following is a risk factor for this condition? Okay, I'll end the poll there. Most of you have gone for D, a family history of autoimmune conditions, and that is correct. The rest of these are all risk factors for type 2 diabetes. So what I've tried to do for each condition is just make a summary page for you with all the key facts that are likely to come up in exams. We'll glance over some of them because for things like type 1 diabetes, obviously, we all know how type 1 diabetics present. But the risk factors for type 1 diabetes include a family history of type 1 and other autoimmune conditions. Aside from that, we know that it's a combination of environmental and genetic factors that link together, for example, an early life exposure to enteroviruses, but it's an area that we don't really know much about in terms of other risk factors. In terms of diagnosis of type 1 diabetes, you can do that through measuring sugar levels using the oral glucose tolerance test or measuring a HbA1c, but the diagnosis of type 1 diabetes should be done by a diabetes specialist. So moving on to treatment, one thing to remember in terms of counselling patients about how to inject their insulin is the risk of lipodystrophy. So that's when the subcutaneous fat at the insulin injection site hardens. So what you want to tell patients is to cycle round your injection sites to reduce the risk of that. There's different types of insulin regimes, and we'll go through those in a minute. There's basal bolus, biphasic, and we can also use insulin pumps. Insulin pumps provide a constant supply of insulin. They're not often used, and there's quite strict criteria. And again, these have to be started by a diabetic specialist, but they're particularly used in pediatrics or where the patient is struggling to maintain their BM or keep their HbA1c in range despite optimal management. They don't measure BMs and respond to BMs and sort of give extra insulin if it's needed. So patients still need to monitor their BMs and then have to program if they want to give a sort of bolus dose if they've got a really high BM. And there are risks to be aware of with pumps, so can get blocked. And obviously you've got a constant long-term device actually sort of connecting with your tissues. So there's obviously an infection risk there. And you can't ever take it off unless you're stopping being on the pump. You know, you don't have any time off that pump in your daily life. Another thing to be aware of is Freestyle Libre, which I think you may have seen many people on, sort of a white button on the outer aspects of the upper arm. That is a continuous glucose monitoring, so reducing the need for patients to take their own BMs. One thing to be aware of is don't rely on the BM coming from that Freestyle Libre. That sort of Bluetooth connects to phones and things like that. There's a delay of about 5 minutes between the actual BM and what the Freestyle Libre is saying, because it's measuring the BM of the interstitial fluid, not of the blood. So obviously type 1 diabetics are insulin dependent, and then in very certain cases you can be eligible for a pancreas transplant or even just an islet cell transplant. These are really only reserved for people who have recurrent and severe hypos, or if they're already having a renal transplant, often due to diabetic nephropathy. Obviously, having a transplant comes with huge risks in terms of lifelong suppression, the transplant failing, infection, things like that. So it's not something to be undergone lightly. And of note, C-peptide, anti-GAD, etc., all of these tests that we're told are associated with type 1 diabetes aren't routinely performed in practice. They're only really performed if there's uncertainty as to whether the patient has type 1 or type 2 diabetes, but they're good tests to remember to differentiate between type 1 and type 2 diabetes. So that's C-peptide and anti-GAD antibodies. Complications of type 1 diabetes, DKA, obviously that's how type 1 diabetes can commonly present, particularly on a first presentation. Hypoglycemia, hyperglycemia, which long-term leads to microvascular and macrovascular damage, and we'll come on to some questions about those. And type 1 diabetics are more prone to infection, so there's a risk there as well. So, as I said, we'd just come on to insulin. So the light blue wiggly line just represents what our normal insulin does in people who can correctly sense glucose levels and release insulin. In a basal bolus regime, you've got a long-acting basal insulin that might be given sort of once or twice a day, and that's long-acting, but also takes a long while to act and doesn't give you a lot of insulin. And then the bolus insulin, the red line, is given around meal times, and that mimics that spike in insulin that we get as glucose raises. Okay. The pros of a basal bolus insulin regime is that you can tailor the amount of insulin that you're bolusing relative to what you're eating. So type 1 diabetics who are really good at carbohydrate counting can give the correct amount of units for the meal that they've just had. So there's a smaller risk of hypo or hyperglycemia. So what I've done is hopefully you can see it, this pink line is a sort of biphasic insulin regime. So that is a mix of short-acting and intermediate-acting insulin. So you would give that combination sort of 2 or 3 times a day, or even just once a day. And that has that initial spike because the short-acting insulin is acting immediately, giving you a high dose of insulin. So you'd give that around meal times. And then you'd give again at meal times to get that sort of second spike that you're seeing on the pink line. And then the intermediate acting just gives you a sort of higher baseline level of insulin. This is more suitable for people who don't want to inject every meal times plus every morning, for example. So it's just, if people are struggling, they're embarrassed, there's quite a lot of social stigma around injecting insulin, this might be a better option. So that's biphasic insulin. Moving on to question 2. So an 18-year-old male with no known past medical history attends the ED after what sounds like some chest infection symptoms. He's got a high blood glucose, ketones are 5, and the pH on his VBG is 7.2. So have a look on the poll. I will end the poll there. We all seem quite split. This was a bit of a tricky question, and I've put in a sort of red herring answer there. Okay, so the key things are he's got sort of infective symptoms. He's then attending with abdominal pain and vomiting. He's got high glucose, ketones are raised, pH on his VBG is 7.2. So what is his diagnosis first and foremost? Can put in the chat. Yeah, correct. DKA. So it's a young chap who's got no past medical history, but based on his blood tests, he's got the 3 criteria of DKA. At some point, we would want to screen for infection, as that's a trigger for DKA, but that's not the most appropriate first. So remember, see it saying the initial management step. IV fluids containing potassium, you absolutely want to give fluids and fluid resuscitate this chap, but you wouldn't start with IV fluids containing potassium, and we'll come on to why in a little bit later. Broad spectrum antibiotics, yes, you'd probably give him some sort of antibiotics to cover chest, and if he's got any other source of infection, but that wouldn't be the most appropriate initial management step. And insulin dextrose infusion, we don't want to give sugar to someone who's already got a BM of 42, at least not to start with. Okay. So the important thing to remember in people who are presenting with DKA is they may not have a diagnosis of type 1 diabetes. They're going to present with your classical symptoms of diabetes, so the polydipsia and the polyuria, but also with more systemic symptoms like nausea and vomiting, hypotension, a change in consciousness, a weight loss, and the acetone smell on the breath from those ketones. Diagnostic criteria, essentially, it's the three parts of the acronym DKA, isn't it? So it's the high BM, the high ketones, and the low pH, indicating that they're acidotic. If you were asked in an exam, in an OSCE, what your management of DKA would be, you're going to say they're acutely unwell, so I'm going to start an A to E approach and get senior involvement early on. DKA does kill, and it's very serious, so don't be afraid to ask for help if you think someone's in DKA, and you really should be seeking senior advice. So the first management step is IV fluids, but you want to use 0.9% saline to start with. We're going to fluid resuscitate this chap and give them a fixed rate insulin infusion. So the rate of that insulin infusion will vary based on your local trust policy, but the standard go-to rate is 0.1 units per kilogram per hour. So just try and remember that. And you want to make sure that you're regularly monitoring BMs using VBGs and potassium. And then based on sort of your trust protocol, I know ours at Aintree is very specifically laid out. At this BM, do this, at this potassium level, do this. It will determine whether you start to give any dextrose and whether you start to supplement with any potassium. Okay, the thing to be aware of is you can give fluids too quickly as well. And this can cause pulmonary edema and cerebral edema. Cerebral edema particularly happens in children. The mechanism to that is not known, but pulmonary edema is essentially just from overloading these patients. You should also be aware of hypoglycemia and hypokalemia, which is why later down the line you'll start to replace sort of the low potassium and the low glucose with dextrose and with potassium. But that's sort of in response to the changing levels rather than as an initial step. Okay, so hopefully that makes sense. I saw in the chat, you're absolutely right. You always give fluids first, but the key to this question is it's 0.9% saline. It's a resuscitation fluid. You wouldn't just blindly give a person. In fact, I would advise pretty much never blindly give a person in practice fluids containing potassium if you don't know their potassium, because obviously potassium by itself can kill. Obviously, people with DKA are at risk of hypokalemia. So you're probably a bit safer here rather than anywhere else to give fluids with potassium, but it's not first line fluids with potassium, it's saline. Okay. Question 3. So a 67-year-old man is diagnosed with type 2 diabetes. His HbA1 is 56 and he started on metformin. Which of these is a potential side effect of metformin? Okay. So I'll stop the poll there. Most of you have gone for C. So Correct. All of these are side effects of diabetic drugs, but they're not side effects of metformin apart from nausea. So does anybody know which diabetic drug has a side effect of weight gain? Pioglitazone, correct. And which drug or drugs have side effects of hypoglycemia? Sulfonylureas, yep, they're classically the ones associated with hypoglycemia. Which drugs have an increased frequency of urinary tract infections? SGLT2 inhibitors, correct. And which drug has a side effect or risk of heart failure? Maybe a bit stumped on that one. It's also pioglitazone. Okay, so coming on to type 2 diabetes, the risk factors include certain ethnicities, so South Asian, Black African, Caribbean, increasing age, a family history of type 2 diabetes, obesity, a sedentary lifestyle, and dietary factors. They present very similarly to type 1 diabetes, but they won't present in DKA. Okay, so polyuria, polydipsia, fatigue, weight loss, and with opportunistic infections. And as we know, the management is conservative, so diet, exercise, weight loss, and targeting certain HbA1c targets, anti-diabetic drugs, and then the detection and management of complications, which we'll come on to in some of the later questions. Does anyone know what this is? Yeah, perfect. Acanthosis nigricans. Okay, so the mechanism of this is not entirely clear, but you may see this in type 2 diabetes patients. It's a sign of insulin resistance, just sort of change in the pigmentation of the skin, particularly in the axillae. In order to diagnose diabetes, we aim for certain sort of targets. So fasted glucose targets, just when you're told sort of we're going to do your glucose testing in the morning, please don't eat anything the evening before, and don't, well, sort of stop eating before midnight and don't have any food in the morning. You'd expect a normal patient to have a fasting glucose of less than 5.5. and a diabetic patient would have a fasting glucose of more than 7. If you then give a glucose load and measure their glucose afterwards, a normal patient would have a BM of less than 7.8, whereas a diabetic person would have a BM of more than 11.1. And the HbA1c for a pre-diabetic patient is 42 to 47, and then a diabetic patient is anyone with a HbA1c above 47. I've more put that in for you guys as a revision reminder for when we send the slides out. As is this slide, I'm not going to talk you through it. It looks horrible and it's incredibly boring, but essentially you just need to learn this. This is the drugs that are used in diabetes, an example of them, the mechanisms of action, and then the common side effects. The target HbA1c for any drugs that are not associated with hypoglycemic episodes. Does anyone know what that target HbA1c is? So if they're not associated with hypoglycemic episodes. Yeah, 48, great. And what's the target HbA1c for drugs that are associated with hypoglycemic episodes? So the sulfonylureas. 52. It's actually 53, but near enough. Okay, and that's because you don't want to overtreat these patients who are on sulfonylureas, so gliclazide, for example, because you increase their risk of hypos. As I said, these slides will be sent to you once you fill out the feedback form, so don't worry about trying to take pictures or quickly memorize it all. So question number 4, a 67-year-old man is diagnosed with type 2 diabetes. This is the same stem as the previous one. He's got no signs of diabetic complications. He's on metformin. Based on this, which of these recommendations is correct? Okay, we'll stop the poll there. So most of you have gone for D, a few of you for E, and a few of you for A. Okay, I can see why you've chosen all of those options, but the correct one is D. So he's got no signs of micro or macrovascular diabetic complications, and he's on metformin. So moving through each answer, A, he should attend biannual screening for retinopathy. So retinopathy screening is annually, unless 2 screenings in a row show no signs of diabetic retinopathy, in which case you then go to biannually. However, although he doesn't have signs of any retinopathy yet, he's only newly diagnosed, so he hasn't had that second screening to allow him to go to biannually, if that makes sense. In terms of foot checks, he only needs an annual foot check unless he's at a higher risk, and we'll discuss what means at a higher risk of complications on the next slide. He's not at higher risk because he's got no signs of diabetic complications. People who aren't on metformin don't need to measure their glucose levels routinely. They may choose to do it if they think they're having a hypo, but it isn't routinely recommended to check BMs. As we discussed previously, when you're on metformin, you'd aim for a target HbA1c of 48, and you'd aim for a higher target if you're on a hypo-inducing drug, such as gliclazide. And he will need to have his HbA1c reviewing at sort of 3 to 6 months, because he's been newly started on treatment. And then after he's sort of, his HbA1c is stabilized, he'd then be 6 monthly checks of the HbA1c. Okay. So just summarizing the screening for diabetic complications, because it's very feasible that you could be asked to counsel a patient on the screening for complications and the management of complications that they'd need to undergo. Most diabetics have annual retinopathy screening, but they're biannually for people who have 2 successive clear screening tests, so clear of retinopathy. Patients need to undergo annual foot checks, but for those who are at higher risk, for example, if they have any deformities, ulcers, active infections, any sensory loss, foot checks will need to be more frequently. That's all detailed on CKS, but I don't think you need to know the ins and outs of what is categorized as low, medium, or high risk. In terms of nephropathy, you want to check for CKD using urine albumin creatinine ratio and Usinase. So that's annually. And in terms of monitoring their diabetic control, if you're not on insulin and you're not on gliclazide, you don't need to measure your BMs. And even if you're on gliclazide, you don't need to routinely measure your BMs, but you might be informed how to in case you get a hypo. And as I said, HbA1c is measured at 3 to 6 monthly intervals when you're on a new drug. And then once your HbA1c becomes slightly more stable, you're then measured every 6 months. Okay, so annually is kidney screening and eye screening and foot screening, and then 6 monthly is HbA1c. Okay, question number 5. A 72-year-old man with type 2 diabetes presents to the emergency department with confusion. He's tachycardic and hypotensive, and he's got some blood results here. So given the most likely diagnosis, which of the following statements is true? Okay, we'll end the poll there. So most of you have gone for E and A. So what is the diagnosis in this man? What's the likely diagnosis? Honk. Yeah. What's his new name? It's not called honk anymore. HHS. Yes, correct. So the key is in his presentation and then his blood results. So although he's unwell, he has a normal pH and normal ketones. So that means he's not in DKA because he doesn't fulfill the 3 criteria of DKA. He's type 2 diabetes, which means HHS is far more likely anyway. And the initial treatment of HHS is with fluids. Don't tend to give insulin in HHS. You give fluids and balance out the... So the problem in HHS is the fact that there's a high concentration in the serum. You have a high osmolality, so you want to give fluids to reduce that osmolality. So the initial treatment is not with insulin and fluids, it's just with fluids. It actually has a higher mortality rate than DKA. I'm not entirely sure why that is. Maybe it's because it's not recognized as quickly as DKA. Again, C, the initial treatment is not with insulin only, it's with fluids. And fluids can, like with DKA, be given too quickly in this condition. It can lead to cerebral edema. And as you give fluids, it can raise the serum sodium, which can lead to central pontine myelinolysis. So if you do that too quickly, giving too many fluids, which can raise the sodium too quickly, you can cause serious adverse effects. Just out of interest, does anybody know how to calculate osmolality? I don't think you'd be asked this in an exam, but it's good to be aware of the components of a rough calculation. No. Solute over solvent, yes. That would be sort of, yeah, concentration, wouldn't it? Yeah, perfect. So 2 times sodium plus urea plus glucose. So in this patient, I've worked it out and the osmolality is 369. A normal osmolality for reference is 285 to 295, and hyperosmolar is anything above 320. I think in a question if they were wanting, I think they would work this out for you potentially, if they didn't give you any of the background. I think with the fact that you can see his glucose is really high, his sodium and his urea are high, but his pH and his ketones are negative, alongside the history and the fact he's type 2 diabetic, I think you can conclude it's HHS without doing a formal calculation of osmolality, and I don't think they'd expect you to do that. So hyperosmolar hypoglycemic syndrome often presents with very high levels of glucose, so even higher than you might see in DKA, so greater than 30 or 40. And you diagnose it by proving that they are hypoglycemic and, oh, I've spelled hyperosmolality wrong there, sorry, and that they have hyperosmolality, and we said that was over 320 using that calculation. And it is in the absence of ketoacidosis, okay, because it's not DKA. So they need to have a normal pH and normal ketones. You may see in some people who are particularly unwell a small amount of ketones, but they shouldn't be positive to the extent that you would see in DKA. And these patients certainly wouldn't be acidotic, okay. So management is with careful fluid resuscitation, okay. So as you give fluids, it reduces the serum osmolality, but then fluid starts to shift down a gradient into the cells, which means that serum sodium starts to rise again. And which is why I was saying before, you need to be careful about how quickly you give fluids, because the quicker you give fluids, the quicker that serum sodium will rise. And obviously this fluid resuscitation will normalize the glucose and normalize the osmolality. You want glucose to fall between 4 and 6 millimoles per hour. So you need to be measuring regular BMs and check that it's falling at roughly that rate and not any more than that, because it will be dangerous and can lead to the cerebral edema and the central pontine demyelination that we talked about before. These patients are also at really high risk of VTE, so you want to make sure that they're given sort of prophylactic low molecular weight heparin as well. And that would be a key thing to say in an exam station. Okay. Question number 6. You're a foundation year 1 doctor. There's a 75-year-old diabetic patient who's become drowsy. They're being treated for a chest infection with IV fluids and IV antibiotics. They're responsive to pain, pale, sweaty, and their BM is 2.1. How are we going to manage them? For the person who has asked when the session is planned to finish, that's a very good question. I'm hopefully aiming for before 8:15. I'm trying to really speed through everything to keep it nice and concise. But feel free to go when you need to, and we can share the feedback link. Okay, I'll end the poll there. Most of you have gone for A, some of you have gone for B. Right, I've put this one in because this is a really common scenario when you're an F1 doctor on call, and whilst you might get asked it in exams, it's even more useful for practice. So there are a few key things to note here. So they're diabetic and they're drowsy. They're being treated with IV fluids and IV antibiotics. Okay, and they're hypoglycemic. Does anyone know roughly what response to pain correlates to GCS wise? No. Okay, so it correlates roughly to a GCS of 8, and that's where we would be unsure of a patient's swallow, which is why if they are non-responsive and we're not 100% sure of their conscious level, you probably wouldn't give something that they could swallow, such as a glucose tablet. You could give buccal glucose, but again, we really want to reduce the risk of aspiration, so it wouldn't be the first line treatment. You certainly wouldn't want to give subcut insulin to someone who's hypoglycemic, and fluids aren't 100% going to help here. You might give them some fluids afterwards, but that's not going to treat the most immediate problem, which is hypoglycemia. The reason that A is the answer is because if a patient has an IV cannula in and they're not conscious and can't swallow, you should go with IV glucose. You could consider IM glucagon, but this isn't one of the answers in this question. I just put for ease. Okay, so this is a common on-call scenario. So any confusion or reduced GCS, think glucose. Remember, don't ever forget glucose as part of your A to E. Make sure to take a BM in these patients. And the things to consider in terms of the treatment pathway: is the patient conscious? Can they swallow? Do they have IV access? I would say in reality, if a patient has IV access and you're not sure of their swallowability, you're just going to be giving IV glucose. Obviously, if you're having to consider IM glucagon, you might want to be looking, sorry, I was just looking at Q&A, because that's a little bit more invasive. You might want to be examining whether they could potentially swallow a little bit more. So you give you treat any hypoglycemia below 4, and often there will be a hospital protocol that's usually on the back of your BM charts, and it's a really good flow chart in an emergency. You just follow that. Give them glucose tablets or buccal glucogel if they are conscious and they can swallow, or IM glucagon or IV glucose dextrose. Reassess after 10 to 15 minutes and then go again if they're still hypoglycemic. After 3 treatments of oral agents, so either the tablets or the glucogel, if BM isn't coming up, you'd then consider IV treatments. Okay. After the BM has come above 4, you'd give a long-acting source of carbohydrates, so things like toast, milk, things like that. and you'd want to be more regularly monitoring their BMs for that period after their hypoglycemia, and probably get the diabetes team to review them. Let's have a look at the Q&A. Oh, the answer to question 6 was IV glucose. A.
Sorry, I clicked answer live before I could click. I wanted to type the answer and then I couldn't go back. So I'll just answer it live. When you give fluid too fast in HHS or DKA, there's just the risk of general cerebral edema. Do you know, Holly, if it's specific for pontine? As far as I'm aware, it's not.
No, I think the difference there is the central pontine demyelination, which is caused by the high sodium, which is caused by the fast fluids, if that makes sense. It's the fast fluids causing the high sodium, which causes the pontine demyelination. But the cerebral edema is caused by fluid overload, but we're not 100% sure of that mechanism. Hopefully that answers it. All right, question 7, 82-year-old female with type 2 diabetes is diagnosed with stage 4 CKD. She has an ACR of 20, no allergies, no comorbidities, and she usually takes metformin. What are you going to treat her with? Okay, we'll end the poll there. The vast majority of you have gone for A, which is the correct answer. So she's got CKD and she's got a raised ACR. So what she's got there is microalbuminuria. So an ACR between 3 and 30 is microalbuminuria, and then over 30 is macroalbuminuria. The reason that's important is because anyone with diabetes who has microalbuminuria should be started on an ACE inhibitor. Okay, so as we said earlier, you screened for diabetic nephropathy with an annual screening, and that's U's and E's and a urine ACR. Part of your treatment is you're going to want to adequately control the diabetes. Lipids, you might potentially consider a statin. And anyone who's then diagnosed with CKD, stage 3 or greater, that should be stage 3 or greater, sorry, not just greater than stage 3, should be started on atorvastatin, irrespective of their lipid profile, because it's protective against progression, an ACE inhibitor, and then a specialist might also consider an SGLT2 inhibitor. So unfortunately, that's just a little bit of rote learning. People who have diabetes and CKD stage 3 or later, or microalbuminuria, should be started on a statin and an ACE, and may have consideration of an SGLT2 inhibitor if they're not already on one by a specialist. Okay. Question 8. A lady's gone for a diabetic foot check, and this is what's seen on her feet. I probably should have done some kind of trigger warning. What is this? Okay, we're torn between, well, actually the vast majority of people have gone for A, and then a few have gone for C. Okay, so yeah, I also agree. I think that's a neuropathic ulcer. It could have potentially been an arterial ulcer. Sometimes it's quite hard to tell the difference between the two. Okay, I will now do a trigger warning because the next page is kind of gross, especially if you don't like feet. Just be aware. So here are your different types of ulcers. As you can see, the venous ulcer is surrounded by more erythema. It's slightly more superficial, whereas the arterial and the neuropathic are a lot deeper. They look like punched out lesions. They're often quite round and deep, and they're often found on bony prominences compared to venous ulcers. usually found on the shins. Okay, so again, that's just a little bit of rote learning. All of them could be present in diabetes. You're more likely to get neuropathic ulcers just because of the diabetic neuropathy. But of course, diabetes can also be associated with micro and macrovascular complications, such as arterial or venous disease, which could then lead to those types of ulcers as well. But neuropathic are almost exclusively found in diabetics. You can also get bony deformities associated with diabetes, and one of the answers, I think, was Charcot's deformity, which, as you can see in the bottom, is a sort of flattening of the whole foot. It wasn't 100% clear to be able to tell that, and the big obvious abnormality on that foot was definitely the neuropathic ulcer. Things to mention in your diabetic foot exam in your OSCEs that you're looking out for is claw toe and hammer toe, and you can see the difference there between the claw toe and the hammer toe is at which angle the distal interphalangeal joint is pointing. So claw toes kind of point more, I guess they're more plantar flexed, if that makes sense. And hammer toe, it's more extended. Question 9. An 89-year-old male has some weight loss. He's a lifelong smoker with a big pack year history. He's got COPD, hypertension, ischemic heart disease, and he's got some abnormal bloods. What's the most likely underlying diagnosis? Okay, great. So most of you have gone for B, small cell lung cancer. Okay, so this chap is likely to have small cell lung cancer, but he's got another diagnosis that points you towards small cell lung cancer. What is that other diagnosis? SIADH, correct. So syndrome of inappropriate antidiuretic hormone. We're moving away from diabetes into the endocrine part of the talk, so apologies, this is quite bitty. There's quite a lot of hormone pathways and testing pathways. Unfortunately, it's a lot of rote learning, and you really need to wrap your head around these pathologies so you can try and understand the diagnosis and treatment of them. So we will come on to explain why that is syndrome of inappropriate antidiuretic hormone. So you can see he's got a large pack year history, 5 kilograms of weight loss. Already you're thinking something nasty, and that's pointing towards a nasty smoking related malignancy type thing. But ignoring that and looking at the bloods, you can see he's got a low sodium, normal TFTs, a normal cortisol, a high urine osmolality, and a low serum osmolality. Okay, so ignoring A and B for now, in Addison's, you could see hyponatremia, and you can sometimes get a normal random cortisol, although I think in an exam question that would be really nasty of them to put a normal cortisol in a patient with Addison's, but you certainly wouldn't get a change in the osmolalities. The osmolalities should be normal, as there's no problem with kind of water absorption or reabsorption. In diabetes insipidus, your osmolalities would be the other way around, and this isn't how patients usually present, and we'll come on to how they usually present in a minute. SSRIs are a cause of SIADH in themselves, so that's another cause alongside small cell lung cancer is the use of SSRIs, but there's nothing in his past medical history to suggest he might be using SSRIs, so that's probably not relevant. So we can see the characteristic pattern of a low serum osmolality and a high urine osmolality. It's classic of SIADH, and the lung cancer typically linked with that is small cell lung cancer. So the causes of SIADH, we've already talked about small cell lung cancer and SSRIs, but it can also happen after major surgery, and hypothyroidism can cause it as well. But you'll note in this patient that the thyroid function tests were normal. That was just kind of saying there's nothing wrong with the thyroid that's causing it. Often patients have no symptoms, but if they do have symptoms, it's going to be of hyponatremia, so nausea and vomiting, lethargy, and then at more extreme ends of the spectrum, confusion and seizures. They are not going to be hypovolemic. So hyponatremia and the causes of hyponatremia are vast, and the key to differentiating the different causes is whether they are euvolemic, hypovolemic or hypervolemic. And the key thing with SIADH is they are not hypovolemic. Okay, they should be euvolemic. The investigations you want to do are thyroid function tests. That's to rule out hypothyroidism. A cortisol, because the first finding you might see is hyponatremia, and one of the common causes of hyponatremia is Addison's, so you'd want to rule out Addison's. You would then want to do serum, paired urine and serum osmolalities, and you would find a low serum and a high urine osmolality. That's because ADH, if you remember, reabsorbs water in the kidneys, which means when you've got lots of it, it dilutes that serum down, so the serum osmolality will be low, and then it concentrates up the urine because there's not as much water being excreted in the urine, so you've got high urine osmolality. You then might consider if all of these, so we've got SIADH confirmed on osmolalities, we've got normal TFTs, normal cortisol, they're not on SSRIs and they've not had major surgery, you'd be wanting to do a chest x-ray or potentially a CT chest to look for the cause of SIADH, which at this point is most likely to be small cell lung cancer. In terms of management, you might often see patients on the ward undergoing water deprivation for SIADH. That can be used to treat the hyponatremia, but it isn't going to treat the underlying cause. So whilst you're searching for a cause, you might water deprive them to increase that serum sodium, stop them getting symptoms of hyponatremia, but continue investigating for the cause and eventually treat that cause. Question 10. A 62-year-old female presents with fatigue, constipation, abdominal pain, and increased frequency of urination. She's got no past medical history and she's had some blood tests, the results of which are shown below. So what's the most likely diagnosis? Okay, we'll end the poll there. You're all split between A and B, with most of you going for A, primary hyperparathyroidism, and you would be correct. So the fatigue, constipation, abdominal pain, and increased urination, what are they all symptoms of? Hypercalcemia, correct. Okay, so she's got symptoms of hypercalcemia. She's got no past medical history. The GP performs blood tests. So you can see she's got a high PTH, a high calcium, and a low phosphate. So PTH raises calcium and lowers phosphate. In primary hyperparathyroidism, where's the problem? Yeah, in the parathyroid gland, exactly. So there's something wrong with the parathyroid gland. It could be an adenoma. It could be a number of things. But what that's doing is it's leading to an increased release of PTH, which in turn is increasing calcium and decreasing phosphate, as we're seeing in this example. In secondary hyperparathyroidism, there's something wrong with either vitamin D absorption or calcium absorption or production of one of those two things. So there's a low calcium, which in a negative feedback loop, that low calcium leads to an increased PTH. In fact, I'm just going to talk this through with this table here so you understand a little bit better. So we've talked about primary. Yep, so in secondary, you're going to have a low or a normal calcium, and that feeds into the negative feedback loop, meaning that PTH production is increased, which is trying to increase the calcium, but there's a problem with the calcium absorption or the vitamin D absorption, so that doesn't increase. The most it will increase to is to a normal level. It will never be high. And then in tertiary hyperparathyroidism, that's when secondary has gone on for a really long time, and then the parathyroid gland starts to become hypertrophic. It may start to autonomously produce loads of parathyroid hormone. So that parathyroid hormone is going to be super, super high to such an extent that it increases that calcium, like beyond, even though there was a problem with that calcium absorption to begin with, the PTH is now so high that it's actually increasing that calcium level beyond normal. What is the common condition that causes secondary and then long-term causes tertiary hyperparathyroidism? CKD, yeah, correct. So obviously there's a problem with vitamin D metabolism in CKD, which will affect calcium absorption. So that's the common exam thing. You'll see a patient with CKD with deranged parathyroid hormone or calcium or whatever, and you've got to determine whether it's primary, secondary or tertiary. Often if there's CKD in the past medical history, you'd be thinking of secondary or tertiary hyperparathyroidism. Okay, let's see. Oh, sorry. I'm just going to go back because I started explaining the different types of hyperparathyroidism. Sarcoidosis, that can cause hypercalcemia by itself. But if sarcoidosis was the answer here, you'd have a hypercalcemia. That would in turn lead to a negative feedback. So you'd have a low PTH trying to keep that calcium under control. The same would happen with drug-related hypercalcemia, and this lady has no past medical history, so it's not going to be drug-related anyway. Symptoms of hypercalcemia: stones, bones, groans, and moans. So kidney stones, bone pain, abdo symptoms, constipation, nausea, and vomiting, and then some psychiatric symptoms like fatigue, depression, and psychosis. That's the classic mnemonic for hypercalcemia, and one of the key causes of hypercalcemia is obviously hyperparathyroidism. Okay. So question 11, 57-year-old male has polydipsia and polyuria. His most recent routine blood tests, including HbA1c, are normal. He has 4 liters of urine output in 24 hours. He has a water deprivation test in which his serum osmolality is raised and his urine osmolality is low. He's then given some desmopressin and his urine osmolality was low after that. This is a really tricky question, guys. Don't be hard on yourselves. If you don't know the answer to this, have a go on the poll and we'll go through which is the correct answer. What I've tried to do is come up with some helpful pathways that when you get sent out the slides, you can try and learn and understand the pathophysiology behind those. We'll just do an overview for now, but you can take time to go away and understand them after. Okay, I'll end the poll there. Most of you have done really well there. Most of you have gone for C, and that is correct. So we can see that he's got 4 liters of 24-hour urine output. Anything greater than 3 liters is raised. He's had a water deprivation test and then desmopressin. So in diabetes insipidus, people haven't got enough ADH. So that problem is either coming from a cranial cause where not enough ADH is being produced, or a nephrogenic cause where the kidney is, there's an adequate amount of ADH being produced, but the kidney just isn't sensing it, so isn't using it correctly. So we know that ADH reabsorbs water, so with not enough ADH, there'll be less water reabsorbed, so more water is going to come out in the urine, which leads to really dilute urine and really concentrated serum. So a low urine osmolality and a high serum osmolality. The first step that you're going to do if you think someone's got diabetes insipidus is just confirm they are actually weeing quite a lot, because patients might think they're weeing quite a lot, but objectively they might not be. So you need to do a 24-hour urine collection and confirm that they're urinating more than 3 litres. Then once you know that they've got polyuria, you will do the water deprivation test and you'll have those findings, as I said. So a low urine osmolality and high serum osmolality. Okay, so you now know they've got diabetes. Another cause of polyuria is primary polydipsia. Essentially, people are just thirsty for no reason. And because they're thirsty, they drink more, so then they wee more. There's not actually a great deal of pathology. The osmolalities won't be affected because of that. They will just have polyuria, but they will have normal osmolalities, okay? Then, so we know now we've done the water deprivation test. We can see the discrepancies in the osmolalities. We're then going to give them desmopressin. So desmopressin is sort of an ADH analog. So in cranial diabetes insipidus, when you give desmopressin, you're giving ADH that isn't being produced in the pituitary. So that then goes to the kidneys, acts, reabsorbs water, and increases the urine osmolality. So you can tell that the cause is coming from the pituitary not giving enough ADH. However, in nephrogenic diabetes insipidus, the problem is with detecting the ADH. So you can give as much desmopressin, as much ADH as you want. The kidneys still are not going to detect it. So the urine osmolality will still remain low in nephrogenic diabetes. Then once you know whether it's cranial or nephrogenic, you might want to do some imaging to see if there's any kind of malignancy or treat the underlying cause, because drugs like lithium can cause nephrogenic diabetes as well. So you'd want to take a thorough drug, past medical history, and potentially do some imaging if there's not any obvious causes for that diabetes insipidus. Okay, question 12, 32-year-old female has lethargy, muscle cramps, and weight loss. She seems more tanned recently, and her blood tests are shown. What's the most appropriate next investigation? Okay, great. Most of you have gone for C. What do we think is the diagnosis here? Addison's, correct. I mean, if we're being technical, it's adrenal insufficiency, but that's most likely Addison's. This lady fits the exact picture. So as we said, water deprivation and desmopressin, that would be for diabetes insipidus, and there's nothing here to suggest she has diabetes insipidus. MRI, pituitary or adrenal glands, they're sort of our next stage imaging. Once we've worked out exactly where the problem is within the hormonal pathway. Hemochromatosis gene testing. These are all symptoms of hemochromatosis, but her FBC and her iron studies are normal, suggesting that the problem isn't with sort of excess iron deposition within the body. And she's got a low early morning cortisol, as well as the characteristic pattern of hyponatremia and hyperkalemia that you typically see in Addison's patients. So you can have different types of adrenal insufficiency. So primary is where the adrenals just aren't producing enough steroids. That's what Addison's is. Secondary is when there's not enough ACTH to stimulate the adrenals to produce the steroids. And then tertiary is the next step above that in the hormonal axis. There's a problem with the hypothalamus. Usually this is due to the action of long-term steroids suppressing the action of the hypothalamus, and then if people come off their long-term steroids or whatever, it then causes adrenal insufficiency and problems further down the hormonal axis. They present like this lady, plus characteristic symptom of postural hypotension. So in young ladies with postural hypotension, hyponatremia and hyperkalemia, you're thinking Addison's. Why do they get bronzed skin? Does anybody know? No. Okay, it's due to ACTH, ACTH, yeah, exactly. That activates the melanocytes to produce more melanin, which makes you look more tanned. So the investigation's going to do use and ease, early morning cortisol, which should be low, but often is falsely normal. Obviously, our cortisol levels vary throughout the day, and if you seem to catch it at a particular peak, even if someone is insufficient, their cortisol levels could be normal. Then the first line test is short synaptin test. You can measure ACTH and you can image. We'll come on to a diagnostic pathway in a minute, all right? So the management is with steroids, and you need to consider mineralocorticoid as well as glucocorticoid replacement, and look in the back of the Oxford Clinical Handbook as to how to manage adrenal crises. I had this as a finals OSCE station. So not meaning to scare you, but maybe learn the dose of hydrocortisone. So you'd want to give 100 milligrams of IV hydrocortisone, followed by an infusion or followed by regular doses. Give fluids, make sure to keep an eye on their BMs and replace sugar, basically, if they're hypoglycemic, and make sure to keep monitoring their electrolytes as well. So if you think somebody's got adrenal insufficiency, you'll do a random cortisol. As I said, it might be falsely normal. Hopefully in the textbook exam question, it's going to be low. So that raises your suspicion of adrenal insufficiency. You then go on to perform the short synaptin test just to confirm it, which will confirm that you've got a low cortisol. So you're giving synthetic ACTH, that's why it's called synaptin. And in people who don't have adrenal insufficiency, giving that ACTH would raise your cortisol, but in Addison's, it doesn't. So, sorry, I should say in adrenal insufficiency, it doesn't. So you're going to have still that low cortisol, and then you're going to measure the serum ACTH and use that to correlate exactly the cause of adrenal insufficiency. So if you've got a high ACTH, that's because of that negative feedback loop. So the adrenals aren't pumping out any steroids, and your pituitary is trying desperately hard to stimulate that steroid production by increased ACTH levels. Whereas when the problems with the ACTH production, obviously ACTH is going to be low, and that causes the low steroid production. Okay, so hopefully that makes sense. In terms of tertiary adrenal insufficiency, obviously, if they're on long-term steroids, that's probably the cause. Okay. Oh, and sorry, I should have said as well, then when you know whether it's primary or secondary, that gives a hint as to where the problem is. So if it's primary adrenal insufficiency, the problem's with the adrenals. So you'd probably do an MRI or a CT scan to look and see if there's any adenomas or malignancies. Secondary, you'd then image the pituitaries to look for any lesions there. Okay, 51-year-old chap has weight gain and a change in the shape of his face. He's got stretch marks, he bruises easily, he has a high random cortisol level, and then we've got lots of stuff about desmopressin suppression tests. So after a low dose, his cortisol is high. After a high dose, his cortisol levels were low, his ACTH levels were high. That's quite a complicated question to get your head around. Okay. We're a bit split, but most of you have gone for B. I've highlighted a lot of that question there. Essentially, it's just the key information, isn't it? Because what does this chap have symptoms of? What do we call it? Oh, I'm so sorry. Yeah, I've written desmopressin, haven't I? Oh gosh, sorry. That doesn't help. Yeah, that's supposed to be dexamethasone. I'm so sorry, guys. That really has not helped with the confusion at all. Yeah, people are all saying Cushing's disease. You got exactly what I meant. I'm so sorry. That's really not helpful. So Cushing's syndrome is when there's too many steroids. Cushing's disease is when that excess of steroids is caused by a pituitary adenoma, okay? But other things that can cause Cushing's syndrome are adrenal adenomas, ectopic ACTH production, which is again most commonly caused by small cell lung cancer, or the use of exogenous steroids. They present with these classic symptoms and signs that I'm sure you all know. And the investigations, we're going to do dexamethasone testing, ACTH, and then imaging, depending on the source. And again, we'll go through a testing pathway and explain that. Management, I've put in bold this transsphenoidal removal of a pituitary adenoma because it just seems to come up in exams, the fact that it's transsphenoidal pituitary surgery. I don't know why, but obviously if that's the source of the sort of increased ACTH, which is causing increased steroid release, that's the treatment that you do. You can surgically remove adrenal tumors. You can also surgically remove potentially things that are causing ectopic ACTH production, like small cell lung cancer, but that might not be surgically possible, and you might have to resort to other treatments. So if you think someone's got Cushing's syndrome, you would give a low dose of dexamethasone. So that can be done overnight or over a 48-hour period. Usually that dexamethasone would feed into the negative feedback cycle, which would reduce the amount of endogenous cortisol being released. But because these people just have a high level of cortisol anyway, that negative feedback loop isn't working. So after a low dose, you'd find that they still have an increased level of cortisol. So that's your sort of initial, okay, they've got Cushing's syndrome, but now what's causing it? Then you give a high dose of dexamethasone. So this would suppress the pituitary adenoma. This is because the problem is within the pituitary and not, the problem is within the pituitary, isn't it? So you give a high dose, and that then finally kicks into action the pituitary gland to go, hold up, we're gonna change our cortisol release here, and that decreases cortisol production. However, if the problem is with either ectopic ACTH production or the adrenal adenoma, a high dose of dexamethasone is not going to change anything, because that high amount of ACTH is still being produced from elsewhere if it's an ectopic source, or that adrenal adenoma is still going to keep pumping out. Regardless of what happens to the ACTH above it, the adrenal adenoma will keep pumping out cortisol. So you get a high level in both of those. So then to differentiate between an ectopic source of ACTH and an adrenal adenoma causing the high cortisol, for both of those, you then check the ACTH. So in ectopic ACTH, that is releasing loads of ACTH. So obviously you're going to have a high level of ACTH. In the adrenal adenoma, there's a negative feedback loop going on because the problem is with the adrenals, not with anything higher up. So the ACTH level will be low. I feel like I've not explained that the best, but hopefully you can go away and read through this pathway and understand it for yourself, okay? Obviously, as before, you'd then image the correct site. So you'd be looking for small cell lung cancers with an ectopic source of ACTH. You'd be imaging the adrenals for an adenoma, or you'd be imaging a pituitary based on all of those tests. Nearly there, guys. So question number 14, 33-year-old female. She's got 3 young children. She's been feeling anxious and sweaty. Some of her blood results are shown below. What is the most appropriate management option? Okay, great. So most of you have gone for C, because what is her diagnosis? Hypothyroidism. And if we're being even more specific, primary hypothyroidism, correct. And you can tell this because the thyroxine levels are high, so she's hyperthyroid, but it's feeding into that negative feedback loop, and the TSH is low, trying to compensate, trying to bring that thyroxine level down. But the problem is within the thyroid. So regardless of the TSH level, the thyroid is still pumping out the thyroxine. So that shows that it's primary hypothyroidism. First line treatment for that is carbimazole. Carbamazepine is an anti-epileptic. We don't want to give levothyroxine to someone who's already hypothyroid. And why in this case, apart from it not being first line, would you not give radioactive iodine? Yeah, young kids. Exactly. So you've got to limit your contact with pregnant women and children if you take radioactive iodine. And you're not going to do you're not going to say no action because she's got abnormalities on her blood test and she's symptomatic. What other options for treatment are there for this lady? Propylthiouracil, great. Anything else? Propranolol, great. Yeah, so you could use propranolol if they continue to have symptoms despite being on anti-thyroid medication. And you can use propylthiouracil for patients who are in their first trimester of pregnancy, because carbimazole is associated with fetal malformation. So causes of hyperthyroidism, spelled GIST with a soft G, so that's for Graves. And obviously the Graves specific features are goiter, the classic eye disease, which includes exophthalmos, you get that pre-tibial myxedema, and the thyroid acropathy. So that is hand swelling and finger clubbing. Other causes of hypothyroidism include inflammation. So we call that thyroiditis. That could be drug-induced or infective. It's a period of hyperthyroidism, then followed by hypothyroidism. The S stands for solitary toxic thyroid nodule, and T is for toxic multinodular goiter. Feel like they're just buzzwords to learn in case it mentions examination findings of a single nodule or multiple nodules. In terms of investigations, to diagnose, you'd want to do TFTs, and you can determine from there whether the problem is with the thyroid gland itself or higher up the hormonal axis. So is it primary or secondary? The key antibodies in hyperthyroidism are TSH receptor antibodies, because they are the ones implicated in Graves. So we talked about all of the management options. And the complications include a thyrotoxic storm. So that's where there's this surge of thyroxine. It presents with things like delirium, fever, tachycardia, and you want to aggressively fluid resuscitate them, give them anti-arrhythmic medications, potentially beta blockers, and you would give them PTU, propylthiouracil, because it's much quicker acting than carbimazole. So that's another time alongside ladies in their first trimester when you'd give PTU first line. Obviously, any drugs or any treatment we give for hyperthyroidism could then cause hypothyroidism if we overtreat people. So last question, guys. 45-year-old lady presents with a low mood. Here are her blood tests. What's her diagnosis? Okay, I'll end the poll there. Most of you have gone for B, but some of you have gone for A. So the problem is with secondary hypothyroidism. So she's obviously got symptoms of hypothyroidism, which is low mood, and her T4, apologies, her T4 is low. So we know she's hypothyroid because her T4 is low. Now, the way I remembered it is, even if you can't quite wrap your head around the hormonal axis, if both TSH and T4 are going in the same direction, i.e. if they're both low, it's secondary. The same goes for hyperthyroidism. If both TSH and both T4 are high, it's secondary hyperthyroidism. But if one is low and one is high, it's primary. And that is because that negative feedback loop is working. There's not a problem with the TSH. So in this case, it's secondary hypothyroidism because that low TSH is causing low thyroxine release. But then there is no negative feedback mechanism because there is a problem with the TSH release. So there's a problem with the pituitary there. We know that it's not C or D because they're not hyperthyroid, and there's nothing really to suggest that she's got thyroid cancer. So the causes of hypothyroidism, the causes of primary can be Hashimoto's thyroiditis, drugs or an iodine deficiency, and causes of secondary hypothyroidism, Sheehan syndrome. Oh, can anyone concisely say what Sheehan syndrome is? Also, tumours can cause secondary hypothyroidism, and I'm talking about pituitary gland tumours there. Yeah, great. That is very concise. Thyroid dysfunction after postpartum hemorrhage. So person has given birth, they've had a massive postpartum hemorrhage, and that has then caused avascular necrosis of the pituitary gland, which is causing an inadequate release of TSH, which is causing that low level of thyroxine release. So your investigations, again, you're going to do TFTs to work out if it's primary or secondary. Hashimoto's can have anti-TPO or anti-thyroglobulin antibodies, so you'd also want to screen for those. And then the management, you want to just replace what they're lacking. So give them, obviously, if they've got a pituitary tumour, you'd look at the resection options for that. But in terms of relieving their symptoms and with primary hypothyroidism, you'd want to give them levothyroxine. So in anyone with cardiac disease or who's elderly, you start them at 25 micrograms per day. Otherwise, it's dosed based on weight. So it's 1.6 micrograms per kilogram rounded to the nearest 25 micrograms. This is something just to be aware of for your PSA if you haven't done it, that levothyroxine is dosed in micrograms, not in milligrams. It's one of those strange drugs that isn't in milligrams, and it's quite a common spot the prescribing error question. So levothyroxine is in micrograms. Okay, thank you very much for bearing with me. That was a lot to get through. We've covered a lot of topics there, and it's really complicated stuff with the hormonal axis. It would be amazing if you could fill in the feedback form for me. Obviously, if you do fill in that feedback form, it's all anonymous, but you'll be sent via email the slides and the recording when we've got it ready for you, which you can use to revise. Obviously, there was a couple of slides there I just glanced over for the sake of time, but they'll be really useful for your revision. And the definition for Sheehan's was avascular necrosis of the pituitary gland following postpartum hemorrhage. Okay, so you're getting that hypovolemia because of a postpartum hemorrhage, which specifically is causing avascular necrosis of the pituitary. Okay, thank you guys.